a little bit. Thank you, Isabel. We also record our sessions so other community members can see them at a later date. So we will be recording. If you do not want to have your face on the recording, you can turn your camera off. We love to see faces, but we also understand that people love to multitask and you might be folding your laundry or doing something else, and that's absolutely fine. We recommend that you stay muted for any background noise while we are doing the presentation, and you can see that the mute button is the little microphone and you're muted when it has a line through it. All right, I already talked about video. Let's keep going, Isabel. So again, you are here at Summer Sun Safety. I want to mention briefly a couple other services at Bronson that you can access either by phone or on the web. If you are looking for a doctor or a specialist in any area, you can do that on the internet, or you can do that via a phone call. If you are a Bronson patient and you use MyChart, lots of times people have questions about MyChart, and you can email this address here, or you can call. So a little bit of MyChart help is always good. If you have questions about a Bronson bill and you are a patient, you can always contact our billing office. And a new feature is, if you would like to get a price estimate for a Bronson service, you can call the price estimator line and they will help you with that. All right, Isabel, thank you. So let's get started with Summer Sun Safety. We're going to jump right into our topic, and people can answer this over the chat if they would, please. And my question of the day is, do you like sunny days? Yes or no? I see a couple of yeses. We were talking about this at our team meeting yesterday. I like cloudy days, but I find that most people like sunny days. So sun is good for us in some ways not. So that's what we're going to talk about today. All right, next, Isabel. So what are we going to do? We're going to talk about how too much sun can damage the skin and the body. We're going to talk about risk factors for skin cancer, and we're going to talk about different types of skin cancer. We're going to learn ways to protect yourself from skin cancer, and you're going to hear about some treatment options at Bronson. And what I would like people to do today is to leave with one thing they're going to do: protect themselves from skin cancer. So we have, go back for a second, Isabel. I just want to ask people, what do we see in that picture there? We see a strap, and where's that arrow pointing? What do we see in that picture? Anybody want to guess through the chat what we're looking at? Yes, Penny says, yes, we're seeing sunburn. And even though the sun feels good, that can be dangerous, and we are going to talk about that. So I want to take a quick minute, and I want to introduce Dr. Bivens, because he's going to be coming in and out, hopefully, of this presentation. He has a specific part of this presentation, but I also want to invite you, Dr. Bivens, to jump in anytime on any of these slides. I know we haven't worked together on them, but there may be times where I'm asking for clarification, and I wanted to introduce him. Isabel, can you spotlight his video? So there we go. There's our Dr. Bivens, and we're so happy to have him here because he is the expert on all things skin cancer today. So thank you, Dr. Bivens, for being here. Oh, and can we test to make sure we can hear you?
It looks like you are on mute, Dr. Bivens.
They should be on the phone.
So I'm actually on the phone and the computer now, so I think the computer is working. So I'm going to turn off the phone.
Oh, perfect.
Okay, can you still hear me?
Yes, that's perfect. I know exactly what happened there. We've had that same echo thing, so perfect. All right, our testing is done. Let's keep going, Isabel. All right, so we did our objectives. Next slide, please. So, question, have you had, and then you can answer this or not, I don't, it's personal question. Have you had or do you know someone who has had skin cancer, yes or no? I am going to say yes, many people. For myself, you can answer this in the chat. Just let us know kind of where you stand on this. Okay, somebody says yes, their husband and themselves. Yeah. So most of us know somebody who has had skin cancer. So we're going to talk a lot about that today and things we can do to protect and sort of how to recognize it. All right, next slide, Isabel. So why do we love the sun? It feels good physically and mentally. It helps plants, flowers, and trees grow, helps make vitamin D. But there are things we should do to protect ourselves from too much sun. Let's keep going and learning about that. We know that too much sun is not good for us. Unprotected exposure to the sun's UV rays cause damage to the skin and premature aging, eye damage, immune system damage, and cancer. So we definitely want to not get too much sun. All right, Isabel, next one. So what are some of the risk factors that exist for skin cancer? Well, it's UV light exposure, whether it's from the sun or tanning beds. UV light exposure causes cancer. If you have fair skin, well, it can cause cancer. If you have fair skin, red or blonde hair, light eyes, you may be more susceptible to skin cancer. And our risk increases as we age. We spend more time in the sun and more exposure to UV rays. Also, if you are experiencing radiation, if you're being treated with radiation, that increases your sensitivity to the sun and also your risk of developing skin cancer.
If I could add,
Yes, go, Dr. Bivens.
so patients that have immunosuppression for whatever reason also are at a significantly increased risk for skin cancer. So particularly patients that have had like solid organ transplants, like liver or kidney transplants, they have to take medicine to keep their body from rejecting the transplanted organ. And that medicine can really increase the risk of skin cancer by like 100-fold in some
Oh
cases.
my gosh, that's interesting. So if you're on an if you have taken immunosuppressants or are taking immunosuppressant drugs, is another risk. Thank you. And I love that you jumped in. That's exactly what I want you to do. So, so do you have any of those risk factors that we just talked about? Yes or no? I know I do. I have increasing age. Yep. Okay. So let's think a little bit about that. And you can kind of answer as we go. I'm trying to watch a chat over here and then look over here, but no worries. Let's keep going.
It looks like somebody said that their husband with a kidney transplant.
Oh, yep, yep. Oh, I see that one. Yep. So that would be a risk factor, definitely. Thanks, Isabel. All right, next slide. All right, so signs and symptoms. So basal cell cancer is the most common. And I am going to just really read these bullet points, and I'm going to then invite Dr. Bivens to jump in related to anything. And then we're gonna show some pictures very quickly of what some cancers may look like, knowing that they all look different. So most common basal cell cancer, and you might see flat, pale, or yellow areas similar to a scar. We're going to show some pictures, red patches that may or may not itch, small pink or red shiny bumps that may have blue, black, or brown areas, and then open sores that don't heal or that come back. So Dr. Bivens, do you want to say anything else about this?
So basal cell carcinoma, like you said, is definitely the most common type of skin cancer. And it's really the most common type of cancer overall. So they estimate like anywhere from like 2 to 4 million people a year are diagnosed with basal cell carcinoma, which is more than all other cancers combined. So this is definitely something that's seen a lot.
Wow, I did not know that, more than all other cancers combined. So yeah, absolutely. That's interesting and huge. Okay, very good. Thank you. All right, next slide, Isabel. So this is just more of a scientific looking picture at basal cell carcinoma. And it's skin cancer is often found in the top layer of skin. Basal cells are found in the lower part called the basal cell layer, which you can see there. And I think Dr. Bivens just told us most common type of cancer and more than all other cancers combined. So that's huge. All right, Isabel, next slide, please. So these next, I know a lot of people are a little touchy about pictures, but honestly, sometimes this is a really good way to look at spots on your body, because I know I am in my 60s and I have different spots on my body all the time, and I visit a dermatologist once a year to check out those spots. And so we're just going to go through some pictures, and as we go through these, I think there's 4 slides. Dr. Bivens, if you want to jump in and comment on any of these, you may. Sound good?
Sure.
All right. Okay, perfect. So these are just some different looking basal cell carcinomas. And what I want to point out is that they can all look really different. And so not one thing is the same with everyone. All right, let's go to the next one, Isabel. So we've just got some different kinds here. So some are flat, some are bumpy, some are black or brown, like we just mentioned. So it can look really, really different. And if you want to read more, you can see on this slide, I took snips of these pictures from the American Cancer Society website. But if you have any of these spots or have seen any of these type of spots, and you go to this website, you can read a little bit more about some of those signs and symptoms. All right.
I guess what I would add to that is you can see that they all look really different. And so it's hard to tell what something is just by looking at it. So even myself, I don't look at skin cancer all day long. And so if I see something, I can say, yeah, that looks abnormal, but I'm not confident enough to say this is exactly what it is just based on how it looks. So if there's something that doesn't look quite right, I always send the patient to a dermatologist just so they can take a look or do a biopsy to make sure that we know what we're dealing with. Some primary care doctors deal with this a lot more than I do as far as just looking at the skin lesion. So your primary care doctor is usually a good spot to start. But if I see somebody in the clinic that has something that looks a little bit weird, I'll just send them to a dermatologist to make sure that it's being looked at.
That's fabulous. And as I said, I go and I'm like, what about this one? What about this one? And they're like, nope, 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 you know. And I will say though, with my husband, and I think we're going to, I might talk about this later, they found a little teeny tiny cancerous spot between his toes. So that's where how a dermatologist, they really look. So yeah, so all right, let's keep going as well. All right, so just some darker spots and what some others may look like. And then the next slide, Isabel. So all different kinds. These are ones that have jaggedy borders, darker in color. But again, Dr. Bivens said, you know, you can't always tell by looking. So a referral to perhaps a dermatologist and then a follow-up with a biopsy for anything that is suspicious is important. All right, next. Okay, so now I'm going to talk just 5 minutes about ways to protect yourself. So things we can do to protect ourselves from getting skin cancer. And most of us know these, but these are just some reminders. Reduce your exposure to UV light, sun and tanning beds. Some people believe that tanning beds are not harmful. They are harmful. So reducing your exposure to direct sunlight, limiting your time during peak hours, which is 10 and 4, and remembering you can still get sun damage on cloudy days like we've had lately. Wearing protective clothing and sunglasses, using sunscreen. We're going to talk about that more in the following slide. And then looking at your skin regularly and bringing that up with your primary care, who will refer you to additional care if needed. All right, next slide, Isabel. So let's talk a little bit about SPF when it comes to sunscreen. So what do we buy? It's hard to decide, right? There's SPF that's 5, there's SPF that's 7, there's SPF that's 15. What do you buy? So SPF tells you how long the sun's UV radiation would take to redden your skin when you use the product exactly as directed versus the amount of time without it. So ideally, an SPF 30 would take you 30 times longer to burn than if you weren't wearing sunscreen. So 30 and up is a good recommendation for the SPF on sunscreens. Any addition to this, Dr. Bivens?
No, I think that's good.
Okay, all right. Next, Isabel. So what kind is best? At least 30 SPF, 50 is better. Broad spectrum, so you want to protect from UV and UVA rays. Waterproof, especially if you're active and you're at the beach, maybe you play tennis, you want to have waterproof. And another thing that people don't do often is apply that sunscreen 15 minutes before you go outside, and don't forget to reapply. All right, next, Isabel. So question for everybody. Who knows? When does most sunscreen expire? How long does it last? If I was at Walmart buying sunscreen this year and it was a new bottle, how long should it last? Does anybody know? Can you guess? Penny guessed 2 years. So the answer is that sunscreen is required to from its bottling, it's required to last 3 years. So they are dated. So look at the date. So what you bought this year, if you have some leftover, should be good next year and possibly even into the next year. So you don't always have to throw it out 12 months later. But if you have sunscreen from, 5-10 years ago, it should be replaced. Okay, so let's talk about sunglasses. I just bought my husband sunglasses. So what kind of sunglasses are best? You want 100% UV protection, UVA and UVB. Look for that 100% UV protection. The color doesn't matter. It can be brown, gray, lighter, or darker. That depends on what you like. But if you have macular degeneration or if you have diabetic retinopathy, amber tinted lenses, people generally see better with those. It doesn't make them better for your eyes. It just sometimes makes it easier to see. And then important to know that a lot of sunglasses say polarized, but that doesn't mean that it's UV protection. Polarization reduces the glare, but it doesn't protect your eyes. So look for the UV protection 100% and look for polarization to reduce glare. So, and then oversized or wraparound are best because sun comes in the sides and the corners too. All right, next, Isabel. All right, so now I'm gonna let Dr. Rivens talk, and he is going to go through his slides, and you can ask any questions via the chat. You can unmute really informally, and he's going to talk about if you have skin cancer or know someone about some treatment.
Okay, so I'll just first start by saying that my slides have a lot of information in them. I'm not going to go through every single detail. They're just kind of there as a reference point to show you where our decisions come from. So try not to get overwhelmed by all the stuff that is in the slides. So I started off with treatment for basal cell carcinoma here. What I have here comes from something called the NCCN guidelines. NCCN stands for National Comprehensive Cancer Network. That's a group of cancer doctors from across the country that specialize in very specific areas of oncology. They get together periodically to come up with these guidelines for diagnosis, treatment, and follow-up for all different kinds of cancer. And so in the presentation here, I pulled guidelines from the basal cell section, the squamous cell section, and the melanoma section. So like I said, we started with a basal cell here. In general, like we said, basal cell carcinoma is like the most common type of cancer that's diagnosed. It's usually a pretty slow growing process, and it's very unlikely to spread somewhere else. So the chance of having cancer start in the skin, that's a basal cell, and then spread to a different part of the body, like the lungs or the liver, that only happens in like 0.1% of patients that get diagnosed with basal cell carcinoma. So it's not one of those cancers that really goes other places and causes problems, but it can cause a lot of trouble in the spot that it starts. So sometimes patients will have a lesion that they just don't know what it is, they don't get it looked at, and it can grow for decades sometimes and cause big problems, primarily just in the area that it started. But this flow sheet here is really just, it talks about what to do if you have a suspicious lesion. You would need to go see your primary doctor usually first, and then they might do the biopsy, or they could send you to a dermatologist to do a biopsy. And if it comes back showing a basal cell carcinoma, we then divide that into a few different categories. So it can be looked at as low risk, high risk, or like I said, there's very rare circumstances where it shows up in different parts of the body. So you could switch to the next slide. Okay, so this table here is the risk stratification for basal cell carcinoma. So like I said, they're divided into low risk and high risk. Certainly nobody needs to memorize all of these here, but the lower risk ones tend to be smaller. They're more well defined. It's usually a primary lesion, so it's not one that has not one that was like removed and then has come back. It's usually the first one. If you are on immunosuppressive treatment, then you don't fit into the low risk category. That would be into the high risk category. And then high risk, those are usually bigger ones. If they look a little bit more poorly defined, so it's not like a circle that you can like clearly see, it can have, you know, more irregular edges. But the main point of this slide is just to recognize that there are low risk and high risk basal cell carcinomas, and they can be treated a little bit differently. So you can go to the next slide. So this here is the algorithm for low risk basal cell carcinoma. So the main thing is to just address the skin lesion where it's at. And so that can be done by several different methods. Sometimes the primary care doctors are comfortable doing these treatments. Sometimes they're not, and then they'll refer you to a dermatologist. The low risk primary disease is something that we don't treat at the cancer center. And I hardly ever see these patients just for this, because they typically don't need medicine that we would prescribe. They just need the primary lesion to be addressed. So it could either be cut out with surgery. Sometimes they'll like scrape it off. Sometimes they'll just put some medicine on it to help keep it under control. And then sometimes if a patient isn't a candidate for surgery or doesn't want surgery, radiation treatment can be considered. If you can go to the next slide. This algorithm here is for the treatment of high-risk basal cell carcinoma. So the first part of it is really kind of the same in that they generally need a surgery or a procedure to remove the primary lesion. And then after that's done, they have to make sure that everything has been taken out. So they look at what are called the margins, just to make sure that there's no evidence of cancer left behind in the skin. If there is evidence of cancer left behind after the initial procedure is done, there are a couple of options. So they can either repeat the procedure to remove it. Sometimes they'll give radiation if additional surgery is not an option. And then sometimes if radiation or more surgery is not an option, we can talk about giving them medicine. But really the main kind of take home message for basal cell carcinoma is if you have it, you know, they just need to take it out with surgery or some other method. The next slide. So this here is for that very rare circumstance where somebody has basal cell carcinoma that has traveled from the skin to some other part of the body. Like I said, that only happens in like 0.1% of patients with basal cell carcinoma. So it's really rare. We do have a couple of medicines that have been approved for treatment in that setting. One of them is a pill called a hedgehog inhibitor. And then the other is a type of medicine that's an IV infusion, which is immunotherapy, which we use for lots of other cancers, but we can use it for basal cell carcinoma too. And the one that's approved is called cemiplimab or Libtayo. Sometimes radiation or surgery can play a role if the cancer only spread to like one spot. But typically if there is disease that's spread from the skin to multiple areas, we're left with medicine as the best treatment. Sometimes even if the cancer spreads to a different part of the body, these still can be really slow growing. And so even if it's spread to the lungs, if the patient's not having any symptoms, sometimes we won't start them on treatment up front, but we can just do close monitoring, because if they're not having any symptoms from the cancer, I can't make them feel better by giving them treatment. So that's something that we do sometimes do. Next slide. Did anybody have any questions about the basal cell section? No? Okay. So this next section here is for squamous cell carcinoma. That is the second most common type of skin cancer. behind basal cell carcinoma. Like basal cell carcinoma, the squamous cell carcinoma generally is not a particularly aggressive disease. And for the vast majority of patients, it stays in the skin and can be removed there. But there are certainly patients where the cancer can travel from the skin to other parts of the body. So it can start traveling to the lymph nodes. That's one of the more common spots that it would go to. And then on occasion, it can travel outside of the lymph nodes into other parts like the lungs or the liver. This here is the algorithm that we would follow for squamous cell skin cancer. And this also comes from those NCCN guidelines. So the whole process is really pretty similar to basal cell carcinoma, where if you have a suspicious spot in the skin, you would either talk to your primary doctor about it or your dermatologist. They would generally do a biopsy, and then they would look at the rest of your skin too to make sure you don't have any evidence of cancer somewhere else or a different skin lesion. If it's just confined to one spot with squamous cell carcinoma, that can be separated into low and high risk also. And then if it's found in the lymph nodes or somewhere else, then it's a different scenario. So if you go to the next slide.
I got a quick question, Dr. Rivers. So
Yeah.
looking at these two different types, squamous cell versus basal cell, as just a person, not a doctor, I can't tell by looking at it what kind of cancer I have, right? Like I can't look at it and say, oh, this looks like squamous cell or so is that correct?
Yeah, I think that's pretty accurate. So even for me, I have a hard time looking at it and saying, yeah, that's basal cell or that's squamous cell. So
Yeah.
I say if I see somebody in the clinic and if there's any question about a skin lesion, I always just send them to a dermatologist, because I could sit there and look at it for 20 minutes, ask a bunch of questions and still not know for sure what it is.
Yeah.
The dermatologist can look at it and say, yeah, that's probably basal or squamous.
Yeah. So important to get to the professional. Thank you.
Yep. Okay, so this here, again, it's not anything where you need to memorize everything on the table, but it's just the table showing the different categories of low risk, high risk, and then very high risk. And so again, it's based on size, some of the factors that they see under the microscope when the pathologist looks at it. And again, this immunosuppression thing pops up here again. So if somebody is on immunosuppression, that would automatically bump them up to the higher risk category. But like I said, certainly nothing to memorize, just something I wanted to make you guys aware of. If we can go to the next slide. Okay, so this is the treatment algorithm again for low risk squamous cell carcinoma. It's really pretty similar to the basal cell one in that you need to just have it taken off either with surgery. Sometimes they'll scrape these off or freeze them. But the margins are also important in this. So if you have the surgery done, they need to make sure that there's no evidence of cancer left behind. If there is evidence of cancer that was left behind, then they would have to consider doing the surgery again. Or if there's been too much taken off or more surgery is not an option for whatever reason, radiation can sometimes be considered too. Next slide. Again, this is for high risk. It's really pretty similar in that you have it taken off and then they assess the margins afterward. If they see evidence of cancer left behind, you need more surgery or sometimes radiation. Occasionally, we'll consider adding chemotherapy to radiation if somebody's had surgery and they can't have more surgery, but we still think that there's cancer left behind. The next slide. This table here is for patients that have squamous cell carcinoma that has traveled beyond the skin, so maybe to lymph nodes or other parts of the body like the lung or the liver. The primary treatment that we use with squamous cell carcinoma that has traveled outside of the skin is an IV infusion of a type of medicine called immunotherapy. There are a couple that are approved right now. That first one that's listed in the preferred regimens, that's cemiplimab or Libtayo. That showed up in the basal cell section too, so we can use it for both of those. And then there's another one called pembrolizumab or Keytruda, which you may have seen commercials for that on TV before. We use that for lots of different cancers, I think they usually advertise for lung cancer on TV for Keytruda, but we can use it in the setting too. When the skin cancer has traveled from the skin to a different part of the body, like the lungs or the liver, we generally wouldn't expect to be able to cure it or make it go away completely, but we're trying to keep it in check as best as we can. These immunotherapy medicines, they work about half the time to shrink the cancer. There are other patients where they might not shrink it, but they keep things stable. And so those medicines are usually pretty well tolerated. And although working half the time doesn't sound like that good of a percentage, when we're talking about cancer treatments, a medicine that shrinks cancer half the time is really a pretty good medicine. There aren't that many that have that high of a rate of success. After the immunotherapy, there are a couple of other options. So just like regular chemotherapy and some other more targeted medicines. It can be a little bit tricky because one of the risk factors for skin cancer is immunosuppression. So patients that have had, like we said, a kidney or a liver transplant, if they go on to develop these more advanced skin cancers and need medicine, we can have a hard time treating them because the immunotherapy, like Keytruda or Libtayo, we don't like giving those medicines to patients that have a transplanted organ because that can increase the risk of rejection of that organ. So sometimes it's a bit of a tricky scenario, but we have to just do the best we can in each individual scenario. Right, the next slide. Did anybody have any questions about the squamous cell section? Okay, so these here are the guidelines for melanoma. So melanoma is the least common of the three that we're talking about today, but it has the potential to be the most aggressive of them. So of all these three types of skin cancer, melanoma is what I see the most of, because for squamous and basal cell carcinoma, patients generally don't have to come to the cancer center because most of them just have it taken off and never need any medicine to go throughout the whole body. With melanoma though, that one, although the vast majority of them are able to just have it taken off and don't need treatment with us, a much higher percentage of these patients do end up needing treatment with us. And so this is what we see mostly as far as skin cancer goes at the cancer center. So again, the presentation and the initial evaluation is kind of similar with melanoma to basal cell and squamous cell. So you have a suspicious skin lesion. So if you're at home and you notice something that just doesn't look quite right, it's always good to go get it checked out. Your primary doctor is a good spot to start. Or if you already have a dermatologist, that would be good too. And so with melanoma, you generally need to have a deeper biopsy done. And then the pathologist will take a look at it under the microscope and look for a lot of specific things that they tell us about it, as well as just telling us what type of cancer it is. So if you can go to the next slide. So this here is the treatment algorithm for earlier stage melanoma. So it's really kind of the same thing as it is for the basal cell and squamous cell, in that you just need to have it taken off from the skin. One difference is that with melanoma, they generally need to do a wider excision to make sure that they get the whole thing. We have to be a little bit more careful about that one. But ultimately, you just need to have it taken off. The next slide. So this here is the algorithm for patients that have cancer that's confined to the skin and maybe has spread to some lymph nodes. And so again, it needs to be taken off. If there's concern for lymph node involvement, sometimes they'll take out all of the lymph nodes. Sometimes they'll do what's called a sentinel lymph node biopsy, where they just take out the most likely lymph node to be involved. And then for these patients, we can give them medicine after the surgery to try to decrease the chance of the cancer coming back. So although the surgery is like the main part of the treatment, even if we think everything was taken off, we can give them medicine afterward, which could be IV immunotherapy, or in some patients, some pills to try to decrease the chance of the cancer coming back. So the next slide. This here is the general recommendations for patients that have melanoma that has spread to other parts of the body. Like I said, it's much more common for melanoma to go to other parts of the body than the basal cell or the squamous cell. For all patients with melanoma, immunotherapy is a first-line treatment option. For people that have autoimmune problems or organ transplants, we have to be a little bit more careful with that and really think twice about giving that. But from a purely treatment perspective, those are always good options for melanoma. There are certain patients with melanoma that have underlying mutations that really drive the cancer growth. And if they have one of these BRAF mutations, we do have pills that we can use to target that mutation to shrink the cancer and slow it down. But obviously, you don't need to memorize all the medicine here. The main reason to put this up is just to show what the potential treatments are for patients that have cancer that's spread to multiple spots. Okay, next slide. So this here is a slide that shows where I got most of this information from. So nccn.org, that's where we get a lot of our treatment recommendations from. In order to get those algorithms that I pulled up there, you need like a healthcare login, but they do have a patient-specific section where you don't have to log into anything. You can just go to the website and then find a bunch of really good, patient-directed information there.
Well, I've got a couple of questions, Dr. Bivens, so thank you. That was really informative. So my two questions are, and then we can, and the others on this call or meeting, you can be thinking about your questions. But first of all, my question is, you've used the phrase treatment algorithm, and I wonder, in layperson's terms, is that a treatment plan, or what does algorithm, the word, actually mean?
Yeah, so it's really a way to standardize the treatment to make sure that the treatment that we recommend here in the community is going to be in line with what they'd recommend at any big academic center. So it's really just a way to standardize things. So it's not like we're cooking up our own regimens here in Kalamazoo. It's based on national guidelines and to make sure everybody's getting the right treatment.
So it's like, if you have this, we do this. If you have this, we do this.
Yep.
Okay, very good. And then my second question was, how likely is it if I have a basal cell carcinoma and I ignore it for 20 years, 10 years, 5 years, how likely is it to progress to a melanoma? Does that progression always occur? What is the how is that related?
Yeah, so those are totally different diagnoses. So I wouldn't expect the basal cell to turn into a melanoma. So the basal cell would just stay a basal cell and continue to get bigger and cause problems that it's at.
And those usually get bigger, go deeper, and cause those localized problems.
Yep, exactly.
Okay, thank you. Those are my two questions. Does anybody else have questions in the chat or unmute? We've got an expert here, so it's really great to get his opinion. Any other questions? There is one question in the chat, Dr. Bivens. How do you know if it's traveled to an internal organ?
Yeah, so with melanoma, if it's big enough or if there are features on the pathology report that are concerning enough, then we would do scans like CAT scans to see if it's gone anywhere else. Sometimes we'll do ultrasounds of the lymph nodes in that area. And that's really how we know if it's gone somewhere else.
Okay. And I'll look for, I don't see any other questions in the chat, but we'll give people a couple minutes. And then as they're thinking, and I know then we're going to wrap up, but if we'll just give a minute, if there's any other questions. I just wondered, so if I show up at the Bronson Cancer Center, where am I in this state? Most often I have a melanoma, right? Because if I had a basal cell carcinoma or a squamous cell carcinoma, I'm probably getting that treated not at a cancer center through my dermatologist or something else. Is that correct?
Yep, that's right.
Okay, very good. All right, well, I don't see any more questions. I'm just going to do a couple quick wrap-up slides. So to wrap up, we talked about different types of cancer today. We talked about basal cell, we talked about squamous cell, we talked about melanoma. Dr. Bivens walked us through what I'm calling a plan, and he says is an algorithm for all of those things. And then we talked about some ways if you do not have cancer or if you've had cancer, protect yourself. We talked about sunscreen. We talked about covering up your body. We talked about not going out in the sun during the prime hours. We talked about getting a good pair of sunglasses. I'm wondering if anybody walked away with what is one thing you will do this week to protect skin from UV rays, and or I'm going to add to this, one thing you will do this week to find out more about skin cancer or a cancer that you might possibly have. So from this presentation, is there any, do you have a goal that you can work on? We really like people to walk away with goals. Someone said, convincing my husband to reapply sunscreen every 2 hours. He's in the sun more than me. That's a really good one. That is a really good one. My goal, I will say for me, check my sunglasses. Make sure I have the right protection on sunglasses. I think somebody else was saying something. Okay, I don't see anything else. So think about it, because again, we want to walk away with one thing we can do to improve our health. And whether it's making sure you get that dermatology appointment, making sure you check with your primary care about a suspicious spot, or just general prevention, all of these things can help you lead a healthier life. So I want to, we already reviewed that, Isabel, so you can go to the next. I want to just thank Dr. Bivens for being with us today. Again, he is at the Bronson Cancer Center and accepting new patients. Thank you so much for sharing your expertise and your time, Dr. Bivens. And I want to thank you all for being here. And I hope that you learned something. And then again, we always leave this slide up for a few minutes if you didn't get a chance to take down any of these numbers or links. And we appreciate you being here. Thank you so much and have a wonderful day.
Thank you.
Bye. And Isabel, you and I can leave that up for just a couple of minutes.